Professor Karima will talk on ovarian reserve, and we, the fertility specialists, when we are dealing with this sort of surgery or this sort of the endometriosis patient, we are always thinking about the preserve the ovarian reserve is mandatory for us, because before doing any surgery, rethinking about the surgery is very important, because previously it is said that the size of the tumor is the indicator. But nowadays, the size of the tumor, symptom of the patient, and the fertility issue all together, we can make the decision for the surgery. Previously, it is said about the gold standard is the laparoscopy for the diagnosis. But nowadays, the 2022 ESHRE guideline, which is published in 1st February in this year, they strictly state that not for all the diagnosis, the laparoscopy is not indicated. So before taking any decision, we, the surgeons, rethink about the surgery is needed or not needed for the patient. And the preoperative ovarian reserve, especially the anti-Malarian hormone measurement, is very important for us, because the anti-Malarian hormone is a reflection of the ovarian reserve. And sometimes in some country, there is some medical legal issue, because after the surgery, the patient can claim us that the ovarian reserve why diminished. But if we do the ovarian reserve before doing the surgery, then it has evidence in our hand that the ovarian reserve is previously less, and we can, before doing the surgery, can properly counseling the patient. So all of these things we should keep in our mind before we are taking any sort of decision regarding dealing with the fertility issue of the patient and who have the poor ovarian reserve, because after that, every patient have an expectation the natural pregnancy. So natural pregnancy is not so easy if the ovarian reserve decline drastically. So after that, the necessary of in vitro fertilization or IVF should think and should counsel of the patient. Yes, Professor Karima. We are now seeing your presentation. Karima, would you please unmute yourself and open the video? Yeah, please unmute yourself. Yeah. And who is playing the slide? Just give the full screen, please. Would you please start, please?
So, yes, sorry for this disagreement.
Nice.
So can I have a screen, a large screen, please? Passez, suivante. So endometriosis, the existence of endometriosis negatively affects fertility by many different pathways. And as we know, surgical removal, it's very dualistic. Complete excision benefits the pain relief and the relapse, but it harms the follicular reserve and the ovarian reserve. So the goal of endometrioma surgery is to remove the cyst without tissue remnants and preserve the ovarian reserve as much as possible. In patients with endometriosis, the choice of expectant management surgical
je m'excuse vous m'entendez? Je m'excuse de vous interrompre. En fait, est-ce que c'est possible de... Là, en fait, on voit les slides sous format de pas présentateur, donc c'est possible de changer le display setting en haut. Il y a un bouton central en haut.
C'est Jada qui s'en occupe. C'est Jada qui s'en occupe.
Abdrahman, il y a un bouton en haut, au centre. En haut, display setting.
We can hear and see perfect way, no problem.
Okay, because this is not the right slideshow, so we are trying to switch the slideshow to presenting mode.
Because it's already long time just gone.
Suivante, c'est Abdrahman.
We can see and hear perfect way.
C'est Abdrahman. So why do we do surgery? Suivante.
I think you can proceed.
The ovarian reserve is directly proportional to the pregnancy rates, and the surgical must be done with the very much care to not harm this follicular reserve. Suivante. And why do we do surgery? Suivante, Abdurrahman. It's a problem, it's a big problem. So, suivante. In the ESHRI, there were guidelines this recent year. We thought it's recommended to do the surgery if endometrioma exceed 4 centimeters. Why? Because it confirmed the diagnostic histologically, it reduces the risk of infection, improve access to follicles, and possibly improve ovarian response. But women should be counseled of the loss of the ovary tissue and the decline of AMH. The decision must be reconsidered if she has previous ovarian surgery, because repetitive surgery must be very harmful to the patient. Yes, suivante. What is the impact of endometriosis? Suivante, s'il te plaît, Abdurrahman. The impact, the presence of moderate to severe endometriosis, reduce AMH, as we said, and not only the surgery that harm the ovarian tissue, but even the adhesion, even the inflammation that give us. You have MSERM that is deposed in the tissue, in ovarian tissue. It's very harmful, and it's block the ovulation and the implantation. So it's really the presence of endometrioma itself harm the ovarian tissue, not only surgery. It's why we must very think about surgery and about the endometrioma prise en charge. Yes. Yes. And what we see that AMH in serum AMH is lower even in women who don't have endometrioma, and it declines through the years. It declines by years passing, and what we see that women with endometrioma in 6 months of follow-up with surgery, a faster decline in AMH levels than in healthy women. It's associated to. So in observational study, Santuli and al. Studied the impact of ovarian endometrioma on infertility, and what they found that the presence of ovarian endometrioma was not a risk factor for infertility, but previous surgery for endometriosis does. It's very controversial. So when we say that endometrioma itself can harm ovarian, but surgery it harms more, and twice and then 3 times. Yes. So we must choose the surgical techniques, and there is 2 techniques that are very known. It's cystectomy or ablation and removal of the membrane. What we should know that there is 2 types of endometriomas. You have type 1, and it's difficult and harder to remove because you have invagination of the endometrial implants. Usually it's smaller and it's harder to remove because there is intimate adhesion between the tissue, the ovarian tissue, and the endometrioma, and we will lose the ovarian tissue while doing surgery. The type 2, and it's the more frequent, it's larger, it's easier to remove, and it's endometrial evasion into functional cysts, and maybe it's this one where we can do cystectomy. By the other one, we better do the ablation and drainage. Yes. So even if we do the cystectomy, it must be with careful dissection of cyst wall. We can do incision drainage, monopolar coagulation of inner capsule, and bipolar, and we we must not exceed 20 to 40 watts to not lose much follicular. And this years we have also laser cauterization, and it's better to do it beside the bipolar. Yes. What are the techniques to minimize the impacts? It's to find the correct dissection plane in order to avoid the resection of surrounding folliculars, and the coagulation of bleeding vessel. It must be, we must do suture more than coagulation, because with coagulation we must lose more follicles. Voilà, please. Donc oui, passe, si j'attends. Donc, the question is the ovarian tissue unintentionally removed functionally normal, or it's the incision and the surgery that it harmed it, or it's, even if we don't do surgery, the AMH will decline through the time. And there is a lot of papers that were seen in this last years talking about this, that AMH is declining through the years, even with endometrioma, surgery also. But there is papers also that show that you have a recovery after 1 year of surgery, recovery of AMH after 1 year. So there was many papers, yes, Shijeda? And donc, yes, Shijeda. Donc, it has been shown that fenestration and coagulation was less deleterious to the ovarian function. However, fenestration and coagulation is associated with higher risk of recurrence than excision, and recurrence may lower the AMH. And what we said, it's the different surgical option. The best one is cystectomy by stripping techniques, traction, counter-attraction, and hemostasis is applied on the ovarian cyst bed with less coagulation and preferred suture. And it's the recommendation by different societies. Okay. What we should know, there is some recovery after 1 year. The physiopathology, it's when we do a cystectomy, you have a recovery of follicle growth. So because it's compress, the cyst is compressing the follicles, and when we remove it, you have a recovery growing, and you must have AMH recovery after that. And in the other side, you can have, you can have low blood supply, and it's in this case when you have more loss of AMH. Yes. In cases of large ovarian endometrioma, a 3-steps approach could be suggested, requiring first laparoscopy for draining the cyst, followed by 3 months of gonadotrophin releasing hormone, agonist therapy. At the end of the medical treatment, a second laparoscopy is performed in order to ablate the reduced ovarian endometrioma. In fact, we do the combined treatment in 3 months, the combined treatment to have more benefits. Yes. And there is a paper in that, including 26 trials with 3,000 women with endometriosis. And we found that combination of surgery and medical therapy appears to be beneficial, increase pregnancy rates. But there is a lack about the appropriate timing. It's if you would do it timing before, after, or both before and after surgery to maximize treatment response. Yes. So in order to avoid 2 laparoscopic procedures, we use cystectomy technique, and CO2 laser is used to vaporize the remaining tissue and and we do the combined treatment. Yes. AMH. What is about AMH and ovarian cystectomy? There is different meta-analysis showed evidence of negative impact of excision of endometrioma on ovarian reserve, and in the late postoperative period, 9 to 12 months, we have 39.5 and 57 reduction in post-operative circulating IMH, and bilateral endometriomas, you have more decline of AMH. Yes. So there is a lot of studies. There is a lot of papers that talking about many papers from all over the world. Yes, Jada. When they talk about post-operative AMH in short time, long term, and they talk about unilateral, they compared unilateral and bilateral laser ablation versus bipolar. It's a large assessing of many papers all over the world and all the characteristics. Yes. And what we find that AMH is lower in the short term. At short term, it's you have it's the 4 here, then 2 of it. It's divided by twice. Yes. When we see short term and medium term, and long term, we see some recovery. If we see here, you only minus 0.75 comparatively with short time when you have minus 162. And when you use bipolar energy or saline agents, it's the same thing. Bipolar or saline agent, we find the same results in the two groups. Laser, yeah, the same vaporization and cystectomy. We found less decline of AMH in vaporization than cystectomy. There is a difference between the two. So we prefer vaporization more than cystectomy. Yes. What about the long term? Subsequent studies assessing AMH level up to 1 year after surgery revealed that this decrease would be only temporary and could recover. And larger prospective studies performed showed that 12 months after surgery, AMH were no different from the preoperative assessments, especially in small cysts and unilateral and stage 3 endometriosis. Yes. And there is a paper that talk about this, and we find complete recovery of preoperative AMH value at 12 months post-operatively. And this paper, it assessed 22 patients undergoing laparoscopic cystectomy for unilateral endometrioma and bilateral endometrioma, and we found that there is no difference between the preoperative and the post-operative. As we see here, there is a lot of studies, and 3 of them show that there is the same AMH in preoperative and post-operative, so or in short term and after that. Yeah. Another paper showed that there is 2 groups. You have one group that it recover after 1 year, and the other one that the declining still go on. And maybe we should explain that by the 2 types of endometriomas, the type 1 and type 2. Maybe the type 2 is we have more recovery than the other one, and it's independent of the expertise of the surgeon. But it's the same. In these 2 groups, you have the same characteristic, but we have we have the difference between them. Okay, yeah. Reduction in AMH level after surgery is higher in bilateral endometrioma. It's inversely correlated with the diameter of the cyst, but the decline is associated with the follicular loss evaluated by histology. Donc, even if we did not do the surgery, AMH will decline, so better doing surgery for this woman. And the reduction intensify, yeah. Donc here for bilateral surgery, bilateral endometriosis, we found in bilateral there's more harm, yes? No, other one, no. Yes, this is between unilateral and bilateral. In 3 and 6 months, we found that in bilateral, the decline is more important. Which techniques should we take for not declining the AMH, for having lower impact? We must prefer suture better than bipolar, and we suture the inner plan and the inner plan to not do the bipolar, to not use the bipolar, and the external plan to not have adhesion after that. So it's better using suturing, and too much papers shows that. Mm-hmm. What is about pregnancy rates and ovarian cystectomy? In the meta-analysis, the chance of pregnancy after laparoscopic excision ranged from 30% and 67%. It's a nice percentage. Other studies show the same rate with 50% in 24 months after excision surgery, and higher AMH level was seen in after surgery for endometrioma. The likelihood of spontaneous pregnancy were 3 times less in other benign tumor. It's, yes. Pregnancy rates on 4 different treatments for endometrioma. When we use surgery and ART, or surgery with spontaneous pregnancy, aspiration and sclerotherapy, or only ART, no difference among the groups, but in only ART, the rate is lower than the other groups. So better doing the surgery. Other? Plasma energy showed more results, better results in pregnancy rates, as seen in some papers, yeah? Does preoperative anti-Malarian influence post-operative pregnancy rate in undergoing surgery for severe endometriosis? It's the same thing, but the probability of post-operative pregnancy was comparable between women with low and normal AMH level. So it's comparable when the women have either low AMH or high AMH. It's the same rates for pregnancy after surgery. We conclude treatment is controversial issue and preservation of fertility in women with endometriosis. Each patient must be evaluated individually according to their symptoms, severity, age, expectation, and risks. AMH must be assessed before surgery, and patients must be informed about the risks and the decline of AMH, and surgery must be done with maximum care and with less invasion of tissues. And thank you.
Thank you. Thank you, Professor Karima, for your very nice presentation. With some technical difficulty is ignored from ourselves, but your presentation is really excellent, and you justified the topic that the ovarian reserve, this is crucial after any endometriosis surgery. And you perfectly mentioned another thing here, the preoperative and postoperative medical management sometimes helpful for this patient. But we have to rethink about the criteria of the patient, which patient is needed for the post-operative suppressive therapy or not, because the recommendation is after the surgery, the fertility resumption as early as possible, that is helpful for the patient. So thank you, Professor Karima, for your excellent talk regarding your topic. Thank you very much.
Thank you. Excuse my English. Thank you. Thank you so much.
Yes, perfect. Now, ladies and gentlemen, we are going to our next speaker.